Hey, what up all my tooth doctors and doctresses? Welcome to another video at the Tooth Factory. Today we're going to be continuing our central nervous system series with anti-epileptic drugs. Dr. Kanan Shah has put together an amazing presentation for us, and I, Dr. Rishi Shah, will be presenting it to you. As you can tell, these are enactments of seizures and has to do with brain electric activity. So, with our table of contents today, we'll discuss what epilepsy is in overview, then look at its causes, the etiologies of epilepsy, then classify different epilepsies, and then discuss mechanism of actions of anti-epileptic drugs. And of course, classify the anti-epileptic drugs. Later on, we'll discuss the in-depth aspects of anti-epileptic medications. Of course, not all of them. There are 24 labeled, but we'll only discuss 10 of them because they are the important ones for our curriculum. And adverse effect of anti-epileptic drugs will also be discussed in short, and then we'll summarize a chart for anti-epilepsies in MAO, side effects, and pharmacokinetics. Now that's an important concept, so we'll discuss that at the end. And then there is a brief blob of status epilepticus in the middle of the slides that I will point out. Again, an important condition that needs to be discussed. Ending with references. So let's introduce epilepsy to ourselves. There are mainly two types. There's focal and there's generalized. Focal means one area of the brain being affected, whereas generalized means all of them being affected, and in other words, it's referred to either as convulsions or seizures. Okay, so let's begin our conversation, of course, with central nervous system overview. We've done that with all of our series with CNS lectures. It consists of brain and spinal cord, balance of various neurotransmitters, elicit various actions, unlike when we talked about parasympathetic nervous system, which only had acetylcholine and norepinephrine. CNS then also is constituent of movement of the body and behavioral patterns, and of course this one has to do with both, in fact, right? Because there's convulsive movements and there's behavioral patterns where we're not attentive to our surroundings, and they are significant in these series as well. So some of the diseases we have already covered are neurodegenerative diseases like Parkinson's and Alzheimer's, psychosis, bipolar, mania. This one's convulsions or epilepsies. Anxiety has been covered, depression, hypnosis has been covered, and of course, the next lecture will be drug abuse and various dependencies. The solutions to these diseases is very simple. You can't cure them. That's something that we need to keep in mind. We can only treat them and prevent them, but we can't completely cure them, as CNS is not entirely understood, right? So the solution becomes to balance the neurotransmitter actions in either excitation form or inhibition forms, depending on the condition. So as we always say, the most important method to mastering any CNS pharma is to be able to understand the basic concepts down to the behavior of the CNS in depth, and that helps us. So without much ado, let's get on. This one we know that it has to do with GABA and glutamate. This is epilepsy. Epilepsy has to do with an increase in CNS activity to the point where we need to suppress it. And therefore, that's where GABA comes into effect. Remember, GABA is an inhibitory neurotransmitter, right? So in this case, we need to balance the excitatory neurons that are extremely fast at firing without control in epilepsies by introducing inhibitory neurons in power. So then becomes depolarization versus hyperpolarization. We've talked about this in our earlier lectures. Please do consider these as a very basic foundation of understanding pharmacology. Influx and efflux of ions that lead to these depolarization and hyperpolarization. Okay, so let's begin with epilepsy overview. It is the third most common neurologic disorder after CVA, which is cardiovascular accident. In other words, it's known as stroke, and Alzheimer's. We've already talked about Alzheimer's, and stroke we'll talk about during our CVS series that follows afterwards. Epilepsy is 10% incident rate in lifetime, which means 10% of the population will go through epileptic attacks. It is a syndrome, it is not a single disease. It's a syndrome of seizures that is caused due to, now here's the important guys, it is caused due to excessive discharge of neurons. So this in itself gives us a big clue that epilepsy is due to excessive activity of the central nervous system. This electrical failure of the brain can cause several signs and symptoms that we can see outside of the body, such as loss of consciousness. In other words, we call it LOC. Involuntary movements. Remember, with behavior came movements as well. There's atypical, distorted behavior and perception, such as foul smell, odd colors, visual, auditory, and olfactory hallucinations that are seen, and all occur in episodes, and that in overall is known as convulsions, epilepsy, or seizures. Like any other CNS pharmacology intervention, the drugs used in epilepsy can cause several side effects and do not cure the root cause of epilepsy. They merely mask the symptoms and control the involuntary behavior of the brain. So we're only going to mask the effects. They don't cure the entire disease. So, like we said, common symptoms, there's loss of consciousness, lots of anxiety, staring into the sky, so no attention, nothing, and they're just staring straight into a zone of void. And of course, there's muscular weakness, as well as there's lots of jerking and contractions of the muscles that take place involuntarily. So, epilepsy etiology, why does it occur? First of all, no identifiable cause. The primary focus is basically the location of the brain that discharges a burst of neuronal discharge, and that's where epilepsy kind of begins. This can be identified by MRI scans or neuroimaging tomography or single photon emission coherence. Now, is this important? Not so much, right? Not important for our sakes, but it's good to know that we can scan the brain in multiple different technologies to understand that there could be a primary focus location that can trigger the epileptic episode. Now, the triggers of the discharges. Why would discharges occur? Many reasons. There's blood gas changes or blood pH changes, blood glucose changes, electrolyte imbalances in the body, such as, for example, sodium versus chlorine versus potassium, sleep deprivation, alcohol intake, and psychological stresses. And of course, genetic does play a role in epilepsies as well. So etiology is genetic, metabolic, and unknown. Unknown is a huge aspect. Genetic, we know that any familial tendencies could lead to a predilection for epilepsies. And metabolic, there could be some tumor in the brain, or a drug-induced epileptic episode, or head injury, trauma, in other words, hypoglycemia, and alcohol withdrawal can also lead to epilepsy. So this is just to show you guys what a single photon emission coherence tomography, or SPECT, looks like. It can be used to measure the regional blood flow in the brain. So all it does is measures the regional blood flow. The image shows an increased blood flow in the left temporal lobe associated with the onset of a seizure. So that all that means is there's so much blood flow to that area that becomes our primary focal spot. Bringing ourselves to the focal area, it is the one spot with high neuronal discharge and then spreading to other areas later on. However, generalized epilepsy is basically where it's multi-directional spread of one focal discharge that affects many areas of the brain over on the other side of the hemisphere as well, such as this meshwork here. Okay, so let's classify the epilepsy further in. Seizures, of course, focal, they're also known as simple or complex focal, and then generalized, which are consciousness lost or no memory involved. So I know that generalized has a lot more categories than focal. That is because focal has to do with one area of the brain. So all it has to do is either simple, which means with awareness, or complex, which is impaired awareness, and that's complex. So basically, when a person goes through a focal seizure from a temporal lobe, for example, or an occipital lobe, they will either have awareness or they will not have awareness, and that subclassifies it into simple and complex. Whereas generalized has a bunch of names under it, which is tonic-clonic, absence, myoclonic, clonic, tonic, and atonic. And that's where this comes into play. Tonic-clonic and absence seizures play a huge role in the classification because they're few of the most common ones, right? Tonic-clonic is a lot of movement, a lot of jitters and jerking movements, known as grand mal. Whereas absence is basically no movement. It's where you just stare off into space, and therefore it's known as petit mal. Grand is large in French, and petit is small in French. But overall, it's the whole brain being affected, or multiple areas of the brain being affected. And of course, unknown is just epileptic spasms that we may receive without any cause. Okay, so like we always teach at the Tooth Factory, we're going to bottleneck our knowledge. We started generalized all the way up in CNS, then we moved into epilepsy overview, then we moved into the generalized and focal, and now we're diving into each of their descriptions. So we call this bottleneck education, guys. All right, so let's take a look at our classification. Focal seizures. Description: it is one lobe, one hemisphere affected. Site-dependent symptoms, depending on where in the brain it is affected, we can determine the symptoms. It progresses to become generalized in many, many ways, such as tonic-clonic, where movement becomes affected because it's spread from this focal spot out. Subclassified into simple partial and complex partial, and both of these are basically focal seizures. Generalized seizures, it may begin local and then progress to both hemispheres. It may be convulsive or non-convulsive. Remember, tonic-clonic was convulsive, whereas non-convulsive could have been the absence, where you just stare into the space for some moments. It may cause immediate loss of consciousness, and this plays a big role in our treatment aspect as well. So generalized seizures, loss of consciousness is huge. Convulsive versus non-convulsive is huge. And focal has to do with either a simple partial or complex partial, and has to do with awareness, whether you have awareness or not. All right, let's classify epilepsies. Loss of consciousness is represented by LOC in this chart. We've described that before. Now, partial, simple, partial, complex. Partial simple is basically no loss of consciousness, no loss of awareness, can happen at any age, and can be up to a single muscle dystonia. Dystonia is just loss of muscle tone. And moving on to complex, now we have sensory and mental distortion, as well as motor dysfunction. And of course, altered consciousness is now possible. The window is open. As we know that partial can move up to generalized, especially tonic-clonic, loss of consciousness becomes our first criteria. Tonic means continuous contraction of the muscle, so the jerking movements. And clonic means rapid contraction and relaxation periods. So when we feel like somebody's jittering really fast and then they relax for a few seconds and then start it again, that's the clonic motion. It's because of the depletion in blood glucose and can lead to mental confusion as well. So remember, this can affect our blood glucose level as well as our focus, and of course, loss of consciousness. Talking about absence is generally limited to ages 3 to 14. It is brief, few seconds, for example, 3 to 5 seconds. It's abrupt, it can happen randomly, loss of consciousness can occur. It is associated with rapid eye blinking as well as staring. But again, 3 to 5 seconds is the brief period usually. Generalized myoclonic. Myoclonic is short episodes of muscle, that's myo, and contractions. Now, because of short, which means rapid contractions, that's where clonic comes into play. So myoclonic. It lasts a few minutes, and ages 14 to 18 with brief jerks movements is anticipated. Moving on to just clonic, it is basically the same thing as myoclonic, but with a little bit more impaired consciousness. So loss of consciousness is expected. And then just tonic by itself is increased tone of extension muscles. Now, not very deeply important to remember this term, but it exists in the classification and it lasts less than 60 seconds. So extension muscles. Atonic. Atonic is drop attacks, and it's sudden loss of muscle tone, and that's a dangerous kind as well because you can self-inflict injuries during that procedure. Okay, the mechanism of excitation inhibition. Now, we know that epilepsy is an excessive excitation of CNS. So, the goal of the anti-epileptics must be to inhibit the neuronal charges. In other words, we need to hyperpolarize the synapse. So, for example, in epilepsy, the epileptic is where the receptor binds to an excitatory neurotransmitter, binding of, for example, acetylcholine. In other words, if we change this to glutamate, for example, glutamate, then it will open up sodium channels. Sodium moves in to the cell, and the entry of sodium will depolarize the cell, causing increase in neuronal excitability. That is excessive movements, focal or generalized, but that's the base of it. Whereas anti-epileptics, such as GABA, where receptors binding of inhibitory neurotransmitters will cause chloride ions to open up, and chloride being a negative charge inside the cell will lead to hyperpolarization. In other words, it makes it more difficult for depolarization or activation or excitation to occur. So that's the mechanism. That's what we need to do to treat epilepsy. So how do we stimulate excitation? By glutamate, we just talked about it, or acetylcholine. Sodium comes in and a positive feedback mechanism takes place, and now we have epilepsy due to uncontrolled neuronal discharges. But how do we stimulate inhibition? In this case, GABA is great. Chlorine comes in, potassium goes out, and action potential is diminished, and we are treated. So that's our main goal molecularly. But let's talk about each drug individually, or each class of drug individually. So the main mechanism we've learned so far is to increase GABA action, right? And it's to inhibit the sodium and calcium channels. The auxiliary mechanisms will be to decrease glutamate action, as well as inhibiting any glutamate receptors. So far so good, guys? Everyone's with me? Perfect. Now let's take a look at this beautiful diagram that we found in our references. So, presynaptic neuron. We know that this is presynaptic, this is postsynaptic. Perfect. Propagated action potential. Now we know that, for example, when a stimulation occurs, such as with sodium coming into the channel and into the presynaptic neuron, a depolarization action takes place, which means action potential activated. And then, of course, vesicular release of all these neurotransmitters take place, and they go to the postsynaptic neuron to cause so-called epilepsy. Correct? Now, remember this. All of these drugs right here have a different function. The excitatory synapses, represented by glutamate, is when either calcium or sodium kicks in, lets glutamate out, and attaches itself to the postsynaptic neurotransmitter. Perfect? Where would we need to stop glutamate? For example, we can stop the sodium channels. We can stop the calcium channels. We can affect the binders that prevent the vesicle release ultimately. Or we can prevent the postsynaptic neurons, such as the glutamate. This is another term for glutamate, guys. NMDA, glutamate. We can prevent those receptors, or NMPA receptor. Like, there's so many ways we could prevent glutamate from acting. On the other hand, inhibitory synapse, we can enhance the action. So same thing. Sodium comes in, depolarizes, vesicular opens up, GABA comes out, and we can propagate GABA's action at the GABA receptors, right? And GABA being the inhibitory, it can prevent glutamate's action competitively. So I'm going to erase this conceptually now, and we'll talk about the drugs that do it. So glutamate. What would stop the sodium channels? We have phenytoin, carbamazepine. Those two are one of the most famous ones, valproic acids, right? These are the terms that we'll look at in the future slides when we discuss individual drugs. What about sodium channels? Pregabalin, gabapentin. Remember, these are GABAs. Then we have valproic acid that blocks the exits as well. right? Topiramate, that blocks this receptor of glutamate at the postsynaptic membrane as well. So those are the drugs that will act at those different locations to prevent glutamate. Now let's talk about valproic acid that increases GABA turnover, as well as, of course, the benzodiazepines, barbiturates, topiramate, and zonisamide. They will also help increase GABA to be active, therefore inhibition to take place even better. So these are just an introduction of the names of the drugs that we will discuss in today's lecture. So keep those in mind. Now, therapeutic strategies to treat epilepsy. Say you have a patient in your clinic, now what? So a newly diagnosed epilepsy, consider starting therapy after the second seizure. Second seizure, very important to remember. The first choice of drug is basically you choose a drug that's appropriate for the patient's type of seizures. Consider toxicity of the agent as well as characteristic of the patient that can handle the drug or not. And then gradually titrate the doses, not impact the doses, just titrate them to that which is maximally tolerated or produces optimal seizure controls. No more than that. Remember, we're now playing with GABA and glutamate here, so we need to be careful with the dosing. However, after all of that done, if the seizures still persist, then a second choice drug comes into play. It is, of course, titrated to control the seizures before tapering and discontinuing the first original drug. If the first drug is associated with significant adverse effects, it should be tapered while the second drug is being added. Again, CNS, right? There's going to be a lot of side effects. Despite of that, if the seizures persist, then we need to have a rational combination of two drugs or another alternative drug therapy. Otherwise, we can expect the best, that the person becomes seizure free. So that's just how we use therapeutic strategies. Now let's introduce those names once again. Note that virtually all of these drugs are associated with multi-organ hypersensitivity reactions. In other words, extreme side effects. It causes rashes, fever, systemic involvement. It can be accompanied by suicidal behavior at its worst. So remember, CNS drugs, incredible side effects. There are 24 drugs in this list. But the 10 out of the 24 that are in orange boxes, those are the ones that we will discuss and they're important for today. That includes benzodiazepine, carbamazepine, ethosuximide, gabapentin, phenobarbital, primidone, phenytoin or phenytoin sodium, pregabalin, topiramate, and valproic acid. We have all heard these names before back in dentistry. So, to understand them in even more depth, we have created these charts, the signature tooth factory charts, you guys. So let's use your pens and papers, guys, and let's get on with discussing anti-epileptics once again. Benzodiazepines. Let's start with the easy one. We have a lecture on this, so please do visit that lecture, guys. Mechanism, it binds to GABA inhibitory receptors. It allows a lot of influx of chlorine ions that leads to further inhibition by hyperpolarizing the actual cell. It increases the frequency, benzo increases the frequency of chlorine channels to open up. The features are, it's an emergency treatment. It kind of propagates GABA to inhibit the entire CNS cell. So it's an emergency treatment for epilepsy or treatment of status epilepticus. And of course, side effects, second sleep effect due to active metabolites, such as for diazepam. Tolerance and dependence is possible as well. Receptor binding GABA and benzodiazepine. This is just a diagram of what we just talked about. Basically, benzodiazepine sits here, allows chlorine to go through, and binding of GABA is enhanced by benzodiazepines. It doesn't act at the same site as GABA, but it enhances GABA's action by causing hyperpolarization, or it makes it difficult for cell to depolarize itself, reducing the neuronal or neural excitability. Perfect. Like we said, for detailed discussion on benzos and barbs, please watch our lecture. It is in the links below for more details. Okay, moving on for the drugs. Carbamazepine. We've heard this. As soon as carbamazepine comes into play, we need to think about tic-doloru, which is trigeminal neuralgia. The mechanism is blocks the sodium channels. Remember that big diagram, guys? Blocks sodium channels. It prevents the synthesis of repetitive action of potential discharge. It prevents the actual vesicular discharge from occurring. So glutamate can't even exit the synaptic areas. Focal seizures, they're used for tonic-clonic in general. So look at the wide range of use of carbamazepine. Trigeminal neuralgia, bipolar disorder, all of these can be treated by carbamazepine. And it is metabolized by the CYP family. The 1A2, 2C, 3A4, it is inducing those microsomal enzymes. Again, a discussion of these has taken place in the past lectures. Please do visit them, as induction of the hepatic cells, the enzymes, is very important to understand. Now, side effects of carbamazepine: hyponatremia. It increases seizures for absence epilepsy. Increases seizures for absence epilepsy. So we cannot use it. This is contraindication. If you have a patient with absent seizures, do not use carbamazepine, guys. Next one is ethosuximide. The inhibition of T-type calcium channels. Remember the big diagram from that previous slide, guys? It prevents calcium channels from activating. It treats absence seizures. So whatever carbamazepine cannot, ethosuximide will. It leads to rashes, ataxia, and osteoporosis. Remember systemic involvement that we used to talk about in side effects? Here it is. Gabapentin. Gabapentin, as the name suggests, it's a GABA analog, but it does not work at GABA receptors, and it does not enhance GABA action either. But it's an analog of GABA. Unknown action, actually. It has a non-linear pharmacokinetic, no plasma protein binding, and direct renal excretion. All of this is good as long as there is no ESRD, which is end-stage renal disease. So low dose for ESRD is necessary. A few drug interactions and a few side effects. Therefore, it's still a good drug for partial epilepsy. Unfortunately, we don't know the mechanism of action, but as long as we know that it's a GABA analog, we need lower doses for end-stage renal disease and less side effects for partial epilepsy in elderly. That's gabapentin. Next one is phenobarbital and primidone. So barbiturates, again, please watch our lecture on it for more detail. Ultimately, it enhances the inhibitory effect of GABA neurons by increasing the chlorine channel opening durations. Remember, benzos was frequency. Barbs is duration of chlorine channels. And primidone will then convert to phenobarbital. So it's just a drug that's precursor to phenobarbital. The features: well, it treats status epilepticus, so just as benzos, it treats the ultimate effects of epilepsy, the status epilepticus condition, especially when benzos fail to treat them. Side effects: it is a drug of concern due to high dependency statistic, and it leads to sedation as well as ataxia. Phenytoin. Phenytoin sodium. It blocks sodium channels at inactive channels. So whenever sodium is inactive, it goes and blocks them. Therefore, it reduces the recovery as well as depolarization of the channels. So it locks the closed doors. So when somebody tries to open them, there's a delay in the action potential. So it can be used to treat, of course, clonic, tonic-clonic, and focal, as well as status epilepticus. How cool is that? This is one of the other good drugs that treats all large issues in epilepsy. It is also a CYP family inducer, especially 2C and 3A, and it saturates in plasma. So the drug that saturates in plasma from anti-epileptic medications, it's phenytoin sodium. Therefore, it becomes a dose-dependent toxicity. Higher the dose, higher the chances of toxicity. It can depress the entire central nervous system because it attacks sodium channels that haven't even been activated yet. So, can lead to nystagmus and ataxia, as always. Gingival hyperplasia. Now we're introducing our dental terminology in anti-epilepsy. It leads to gingival enlargement, also known as DIGO, drug-induced gingival overgrowth. Again, we'll talk about this in detail in periodontics. Peripheral neuropathies and osteoporosis. This is systemic effects. One of the best drugs to be used with one of the worst side effects. Moving on. So this is what we meant with gingival hyperplasia due to phenytoin sodium. The papillas begin to grow over the teeth, causing negative recession on periodontal charts. Negative recession, it means gingiva is overgrown, it came up. And then it becomes very important to keep the sulcus clean of plaque, otherwise it can eventually lead to gingivitis and periodontitis. So this chart is important because it helps us understand the plasma concentration. Remember the terminology that it is saturating in plasma? Well, this is the description. When hepatic hydroxylation, which is the metabolism, liver metabolism of the drug, it becomes saturated, small increases in the dose of phenytoin can cause larger increases in the plasma concentration. That's what it means by saturation. So when the liver gets tired of metabolizing phenytoin, even the smallest increase in the dose of phenytoin can lead to large effects because it saturates in plasma. So it has this graph right here. Moving on to pregabalin, it binds to alpha 2 delta site of calcium in CNS. So all we need to know, calcium channels. Inhibition of the CNS discharge itself overall. It treats focal, treatment of diabetic peripheral neuropathies, very important. Post-herpetic neuralgia, again very important. And fibromyalgia, also important. Pregabalin is capable of treating all three of these CNS conditions. Side effects, weight gain, peripheral edema, and 90% renal elimination. So again, dose adjustment needed during ESRD. Topiramate. It blocks sodium channels. It reduces calcium channels. And carbonic anhydrase inhibitor. It inhibits glutamate sites as well. Features partial and primary general epilepsies, migraine prevention, and CYP2C19 inhibition. Now, do you need to know this? You probably don't need to know this. All we need to know that it acts opposite to phenytoin and carbamazepine, because phenytoin and carbamazepine, they induce the liver enzymes, whereas topiramate flips itself and inhibits liver enzymes. Side effects, weight loss, paresthesias, renal stones, glaucoma, oligohydrosis, that's basically sweating, guys, and hyperthermia. So is topiramate the best drug to use? Probably not. Valproic acid, another king drug. Sodium channel blockade, very important. GABA transaminase blocker. In other words, remember ACE means to break down. Whenever GABA is prone to being broken down, valproic acid prevents that and GABA lives. It also has effects on calcium channel reduction. Lots of important mechanisms and features. It treats focal and primary generalized epilepsy. Valproic acid is available as a free acid. Then it's degraded in the GI tract. And of course, this drug right here, which is Devalproex, is sodium valproate and valproic acid both. See, because how valproic acid being a free acid, it degrades in the GI, the sodium valproate cover helps fight that degradation and increases its effects. And this also inhibits CYP2C9. Again, this is inhibition of liver enzyme, unlike phenytoin and carbamazepine, opposite of those two drugs. And if we need to know this, there's a lecture that we have on other CNS drugs that has details on the CYP2C9, as well as in our pharmacodynamics and kinetics lectures, you can find out the liver enzyme activities. Side effects of valproic acid: rare hepatotoxicity leading to increase in liver enzyme because it inhibits the metabolism of other drugs. It leads to teratogenicity, very, very important side effect. Impaired cognitive functions of babies at 3 years of age due to in utero exposure. So, teratogenicity, it affects cognitive functions of little babies up to 3 years of age when the mother takes it while the fetus is in the uterus. Adverse effects of anti-epileptics: nausea, vomiting, the king of side effects. Sedation because CNS is depressed, teratogenicity such as valproic acid. Osteoporosis, there's a couple drugs that we did talk about that causes osteoporosis, systemic diseases. Ataxia, which is just not being able to move with coordination of the brain. Rashes is one. Hyponatremia is another side effect. Weight gain or weight loss can both be led due to systemic side effects. Our resources for today, you guys, are Pharmacology from Lippincott, Lytton Fallis for managing those medically compromised patients. The links are in the description box below. Thank you for watching our anti-epileptic lecture. Hope you enjoyed it. And for more academic lectures in dentistry, please stay tuned to the Tooth Factory and like, share, and subscribe. Have a great day. Thank you very much.